Okay, well, I think we should start. It's the top of the hour. I want to welcome all of you for attending today's webinar, Understanding American Indian Perinatal Care and Cultural Considerations by our special guest speaker, Avis Garcia. My name is Megan Dotson, and I'm the program manager for the National American Indian and Alaska Native Mental Health Technology Transfer Center, which is who sponsors this event. We are located in Iowa City at the University of Iowa, and we're part of a national MHTTC network. As you can see from this map here, there are 10 regional offices and 2 national centers. So this webinar is sponsored by SAMHSA. The content is developed by the presenter, and the opinions expressed do not necessarily reflect the views or policies of SAMHSA, HHS, or the American Indian and Alaska Native MHTTC. Following today's webinar, you will receive a follow-up email, and it'll include links to the presentation slides and the recording, information on how you can request and receive CEUs or certificates of attendance if applicable, and links to our evaluation survey that we call GIPRA. And at this time, we are gathered here virtually today again. And although it's virtual, we want to take the time to acknowledge the land and pay respect to the Indigenous nations whose homelands were forcibly taken and inhabited. Please take a moment to read this land acknowledgement, which was created by 3 members of our team, Ella and Keely Driscoll and Sean Bear, all of the Meskwaki settlement. And this will also be included in your handouts if you didn't get a chance to read all the way through. And with that, I'd like to have Avis introduce herself as she knows herself the best, and she can give you some information on her background and what she does. So Avis, I'm going to turn it over to you and stop sharing my screen, and you can pull yours up and we'll get started. Thanks, everyone.
Okay. My name is Avis Garcia, and I am an enrolled member of the Northern Arapaho tribe from the Wind River Reservation in Wyoming. I am also Eastern Shoshone from my father's side. I have about 20 years of experience in the mental health and substance abuse treatment field, with a good majority of my work with the American Indian populations. I have worked with all ages of clients, from little children to our elders, and I am presently in Crow Agency, Montana, where I am the director of Absalokai Healing. That is our outpatient substance abuse treatment program. We are under a 638 contract with Indian Health Services here. So I have been here since June. So I've been here for like just a little over 6 months now, and I'm really enjoying working here. Prior to that, I was in Cheyenne, Wyoming, as an executive director of an outpatient nonprofit agency. And when I found out about the opportunity to come here, I was pretty excited. So far, I'm really enjoying being here. We've been having some really nice weather. Me and Megan were talking briefly about the weather, comparing weather from where we're at in the country. And we've been having like temperatures in the 50s. So it's been pretty nice here, and I'm not going to complain. I'm going to enjoy it while I can. Today's presentation is, the title you can see here is Understanding American Indian Perinatal Care and Cultural Considerations. And I always like to share with everyone that, you know, I don't mean any disrespect to any other tribes, but I always present from my own viewpoint as an Arapaho person. So you can kind of, there are a lot of generalities, but those of you that know the differences, from tribe to tribe. Like I'm being here working with the Crow people. I'm really glad that I have a cultural counselor here because I oftentimes have to compare notes with him and make sure that I'm not, overstepping any boundaries here or being disrespectful to anyone in my work. So today we will, the objectives that will be covered will be some of the history of perinatal care, talking about our culture specifically, the importance of prenatal care, some themes identified as barriers, and solutions to the barriers. Let me get this, got this in my way here. Prenatal care, according to the Indian Health Services, prenatal care in the first trimester for American Indians, only about 66.5% of live births for the whole, excuse the typo there, I'm gonna have to go back and fix that, should say Indian Health Service population as compared with 81.3 for the United States of all races. So there's a significant difference in the amount of women that seek care in their first trimester. Early and regular prenatal appointments provide the opportunity for women to receive information and counseling regarding their pregnancy, as well as maternal and fetal screening, as well as diagnosis and treatment complications that might be present may also be discovered. Interventions are helpful in further reducing the rate of preterm delivery, low birth weight, substance-exposed pregnancies, and alcohol syndrome and infant mortality. So the first trimester is very important because that is where most of the rapid brain development in the fetus occurs. So that first 90 days is really important, and a lot of women don't realize that. Some women may not even know that they're pregnant that early. So they may have already engaged in substance use and not have been aware that they were pregnant, but that is the most rapid brain development in the fetus. There's my arrow here, sorry. The importance of prenatal care. Let me back this up, okay. American Indian women are less likely to obtain prenatal care in the first trimester. Research has focused on understanding why that is. Are there any barriers present? And prenatal care objective is primarily preventive. So we want to make sure that any complication that could possibly go wrong can be addressed, targeted at prevention and cessation of substance use during pregnancy. Prenatal care outcomes are to enhance the possibility for appropriate health-related intervention. I know diabetes is quite high on most reservations in the Native population, so that can create some unique complications that many women have to address. And I know that from family members that have shared with me that they've only been diabetic when they were pregnant. Also to reduce maternal and infant mortality. Existing literature points to the importance of non-Native practitioners understanding the unique history of Native people and its impact of this history on contemporary realities. This includes understanding the legacy of historical trauma and the related unresolved grief from those traumas. The importance of prenatal care, again, it is primarily preventive and to get information and counseling about their pregnancy. Interventions are helpful, especially the substance-exposed pregnancies to prevent fetal alcohol syndrome and infant mortality. And it is also, again, to reduce that infant mortality. And my work in substance abuse has been one where I often get these stories of women. I had one, well, a couple very recently have come in for an evaluation. We send them off to treatment, and I don't know why we didn't catch before they left that they were pregnant, but some of these women find out they're pregnant after they get to treatment when we send some of them off to residential programming. So that often can create some unique barriers, but the programs that they've been at have been really good at making sure that these women get the care that they need. Late or no care. There is an increased likelihood that the mom might smoke, consume alcohol, or ignore a physician's advice regarding vitamins, diet, and exercise. So some women might be pregnant and not go to get care right away, or many don't go at all. Some women just wait till further on into their pregnancy and not realizing how important it is to take care of themselves. And of course, infant mortality rate is 22% higher among all races. So it's sad that most Native Americans, when we look at these social problems, that our percentages are much higher. This can be complex and varying. Forces that influence a woman's attitude toward prenatal care can be social, psychological, behavioral, environmental. Some women, may depend on where they live, biological, or socio-demographic. There are several dimensions to using care, including a woman's awareness of her pregnancy, acceptance of the pregnancy, self-care behaviors, communication with family members, communication with the partner, social attitudes toward prenatal care, availability of prenatal care, and her attitude towards the healthcare providers in general. Some access barriers can be the time, the cost, and the lack of transportation. Can also include internal thoughts or emotions, mental health issues, problems with substance abuse, or a history of domestic violence. Talking about mental health issues or other issues that could be involved. I had a woman just here early this morning at my desk, who was making a special request to not have a man be providing her treatment at all while she's here in our program, stating she has some personal trauma issues. And so we were sitting here brainstorming how we could work around that to meet her special request. And so we have to be understanding that some of our women, especially in the substance abuse field, have been through a lot of trauma in their life. The history quality, there have been a lot of negative experiences with healthcare in the past. This is in regards to the relationship between the patient and the physician, and the provider with a personalized knowledge of patient. They should show respect and listen to the patient, and working on improved relationships leads to improved effectiveness of healthcare. So there have been, according to the research that I read, that a lot of women in general have had negative experiences with healthcare providers, especially in Indian healthcare service units, because I would say a majority of the physicians are not Native, and I don't know how much they put into understanding the culture of where they are working when they're there. So it is important to have a basic understanding that American Indian women are less likely to seek early and ongoing prenatal care. The purpose of this presentation is to develop an understanding of prenatal healthcare experiences for a Plains tribe. So this is from research that I did, and also to discuss potential solutions to address these health disparities. The primary aim today would be to identify a broad range of interventions and perspectives that positively affect pregnancy outcomes. So, what is the latest that's proven to be effective, and to reduce infant mortality in Indigenous communities. The historical trauma response is a cluster of symptoms or behaviors such as depression, self-destructive behavior, suicidal thoughts and gestures, anxiety, low self-esteem, anger, and difficulty recognizing and expressing emotions. So, not only are they just coming in for prenatal care, we need to look at the flip side of that, of what this person could be experiencing, that, they're not just here to make sure that their health is good for their baby, but there may be some mental health issues that aren't even being addressed. So I really feel that it's important for the physicians to take a closer look at services they provide to American Indian women. There are communication barriers that were identified, and this is physicians who appear to be too busy to ask or respond to patient-related questions. Many women felt as if the physician did not care about them. And, historically, there is an overall lack of trust, not in just physicians, but in non-native people that we receive professional services from. And a lack of understanding modern ways of medicine. It is important to teach new Indian health service providers culturally appropriate methods of interaction. And like I said, there is a lack of trust of non-native physicians and modern medicine. So there's always those people that are hesitant based on their own personal reasons. And then also looking at cultural loss for subsequent generations. And that is one of the reasons I have a cultural counselor on board here. Is I really feel that knowing one's culture as a part of their identity is really beneficial to their well-being here. So we offer a lot of cultural programming at our treatment program here. And this is some quotes from some negative experiences that I've read. Here's one person that said, the doctor said I was going to have a C-section, but he wrote in my chart I was supposed to have a natural birth. So after being in labor for 4 days before they did anything, they finally bring in a specialist. They knew things that were wrong, but never informed me until my son was born. And they said they knew ahead of time, but was never told. So it's things like this that really can create some problems, especially with trust. It is stories about these substandard experiences that deter many women from seeking care during pregnancy. Many women, felt discouraged from seeking care because they heard stories like this from other people. And so based on that, they immediately distrust the provider or the whole healthcare system in general. Something was missing. I made it to all of my prenatal visits. I knew there was a lot more information that I wanted to know, but I didn't ask for it. I didn't know if they had it anyways. It was never offered. I went to the checkup and then they were done and there was no Q&A afterwards. So they weren't asked any questions. They didn't ask any questions afterwards. And I often find that, I share with people from my own personal experiences in life, like just to do the presentations that I do now today. Probably 15 years ago, I would never get up and talk in front of people. So it's something I know culturally we're taught to be more, in my culture, especially the Arapaho culture, is being quiet and listening to the other person. So we respect the person, especially when it comes to dealing with professionals. And I deal with this with some of my own staff here. I have one in particular who is really, really shy. Like she gets really nervous when we put her on the spot and get her to speak up. And so we've been working on that with her. But then there are women that have, not all women had negative experiences with communication barriers, with several stating that they did have good experiences. However, even in those positive experiences, many women still feel there's something missing. This highlights the need for ongoing quality assurance measures, such as teaching new Indian health service providers about culturally appropriate methods of interaction. So as part of quality assurance here, every person that completes treatment here, we have a questionnaire that we have them fill out when they leave so that we can use that feedback as we do quality assurance annually here. So some solutions to these barriers, 3 themes came out in the research that I did. And this was looking at the barriers to prenatal health care. So there were communication barriers, institutional barriers, and some other barriers that you'll see as we go forward with this. Here are the institutional barriers. Long wait time for short appointments, too long of a wait, lack of a waiting room area, especially for pregnant women. American Indian women reported seeing a different physician at each appointment, so there's a lack of continuity. And a different provider at each visit doesn't allow trust to build up a relationship between the woman and the provider, and feeling violated every single time. And I can relate to all of these. Even at the Indian health services here, you know, we sit there and wait for a long time, then they get you in the room, and then you wait even a long time in the room. And then when they finally come in, they're not even in there very long. And I can't remember who I was talking to recently. I did say, I think it was the CARF reviewers that we had, because I said, we have no control over the Indian health services when we send people there. They get, even myself included, when I go to the clinic here, it just depends on who's there. You don't always get that same doctor when people want you to, well, who's your doctor? And it's like, well, whoever is available when I need services. So there's lack of continuity for most people in general. So, but I think this research really makes a good point in that women, especially when they're pregnant, need to have that continuity and have a doctor that they can build a trusting relationship with. And they just can't do that if the person that's helping them is different every time. Communication barriers mainly deal with relationships between a pregnant woman and her provider. And there is a strong preference for a female provider. And, you know, as a woman myself, I can personally relate to this. I'm, you know, not comfortable with the male provider, even a male nurse. I've been to a clinic where they had a male nurse and he was trying to be reassuring. And I was like, no, I'm just not comfortable with that, especially when it comes to dealing with female issues. Some other barriers are transportation issues, our work schedules. In the community I'm in, there are high rates of poverty, so there are people that don't have transportation to get anywhere. So we have to find resources for them to help them with that. A working single mom and unable to make all the appointments because, you know, everything's depending on her. So there's a special barrier there. Other serious interpersonal problems, which include the high rates of poverty, sexual or physical abuse, depression, and substance use. So when these women come in to see the doctor, we have to be mindful of these other things that could have possibly occurred in their life or have occurred. Being in the mental health and substance abuse field, you know, I see and hear a lot of things that are very heartbreaking, but we need to, I think, also be trauma informed when it comes to working with Native women. And like I said, they do not want to see a male doctor. Just like I was sharing with you, you know, I had a woman here requesting to not have a male counselor. And that the women also showed the preference of a female nurse midwife. In other words, the stress experienced by a mother during pregnancy impact the child who is entirely dependent on the mother while in the womb. The presence of stress hormones in her system, all these things affect her child. Just the way she eats and sleeps, an infant with a stressed mother has difficulty regulating and managing their own stress reactions later in life. This can include a predisposition to diabetes, depression, and anxiety. So it's important to, help these women learn how to manage stress in their life. Some solutions could be communication between the woman and the provider. There's a suggestion to see a single provider throughout the entire pregnancy, especially a nurse midwife if available. Nurse midwife might be a preferred provider based on the one-to-one individualized interactions. Additional funding for these positions would be helpful to holistically meet the needs of American Indian prenatal patients. Institutional barrier, supplemental appointments such as home visits and help with transportation by outreach workers. Emphasis on culturally appropriate education, intervention, and prevention. Overcoming communication barriers with the provider. Adding a traditional elder woman on pregnancy and health care, and baby care items as incentives to attend prenatal health care appointments. Some interpersonal barriers, multiple options for treatment for pregnant and newly parenting women, drinking or using narcotics. Women living in rural isolated areas have few options in relation to treatment and programs, especially those that are culturally sensitive. Case management services and a referral system are imperative to guide women to the appropriate system, such as social services. Homeless or domestic violence shelter referrals or treatment programs. And needing programs for partners and fathers are also important. Women-centered should be culturally focused care, specific women's clinic with family planning options, include traditional ways at Indian Health Services, and of course with 560 something federally recognized tribes, we all have different beliefs and cultural practices, so it's important to be knowledgeable and being able to pass on that knowledge to these women as they're preparing to become parents themselves. The clinic should be focused on the women's needs. There should be a promotion of a nurse midwife program. Young women who saw a nurse midwife were happier, felt the nurse midwife spent more time with them. Some discussion. One of the first, some of the research that I read showed that this was one of the first qualitative studies to identify specific barriers to prenatal care, and it's important to understand the health disparities and to look at policy development. All of these services that I just mentioned that would be beneficial are perfect examples of policies that would be specific to this type of care for perinatal care. And the overall quality of care, interaction with healthcare providers, and worth or lack of worth women identify with may inhibit their care. Communication barriers, according to the American Counseling Association, multicultural competence is an ethical mandate. Indian Health Service physicians who seem too busy to ask or respond to patient-related questions. They may be rushing to see so many people that they don't stop to take the time to make the patient feel understood or appreciated. Like I said, feeling that they just weren't cared about, which only adds to that lack of trust. And some of the women stated that, they didn't like the long waiting time for appointments, the lack of continuity, long waits. They felt it was a waste of their time. Some people have transportation difficulties and just being uncomfortable seeing a male physician altogether. Some solutions would be improving the patient-provider communication by encouraging appropriate education, intervention, and prevention, training healthcare providers, having pregnant women work with community elders, implement solutions to communication barriers will lead to better education on prenatal issues, and more satisfactory care depends on more attention to interpersonal relationships between caretakers and patients. I was sharing with my staff the other day because we were talking about how we seem to be seeing more women coming into treatment here that are pregnant. And, you know, what services are we offering here to them? And several years ago, I worked at the Indian Health Services on my own reservation. And we ran a pilot project, and it was called Best Beginnings. And it was based on child abuse, neglect, and prevention. It was a child abuse prevention intervention program. And it did include healthcare people that went into the home, and, you know, we provided transportation to those that needed it. We brought in elders to teach about, you know, taking care of your baby and taking care of yourself while you're pregnant. So, I mean, being able to offer those types of services, I think, would be really beneficial. And there is a new program here on the reservation that just came out, and they are doing something similar to that, but they also included a program for the fathers. So I thought that was something that was really good for me to hear, that not only were they looking at helping the mothers early on, they were looking at the fathers, offering some services to them, because oftentimes there's nothing for the men when they're, you know, going to be a father themselves. So we look at policy changes. They could be used to encourage early entrance into prenatal care. Patients are more satisfied with their care if they waited less than 30 minutes. Too short and too impersonal leads to a bad impression. And maintaining patient-centered care and positive relationships between the provider and patient can lead to better opinions about the care and greater use of the care. Many women prefer to have a single provider, especially a nurse midwife, prefer a female provider. The quality of interaction is often associated with trust, which also associated with them attending more appointments. So the more trust they felt, the more they attended their appointments. And clinic staff don't have time for teaching patients. So it would be looking at, you know, what staff within the clinic itself can offer some educational information to the expectant mothers. The quality of care, with the higher rates of infant mortality and very low birth weight, there could be some transportation and monetary incentives. Like I talked about, the home visitation and cultural broker programs as excellent models of encouraging early and consistent prenatal care. I think a lot of women just think, oh, I'm feeling fine, I should be fine, so I'm not going to go to this appointment, but it is important to go as scheduled. Some real impacts. The first step in understanding prenatal health care experiences for American Indian women. Future studies of other tribal communities are necessary to more fully understand the complex issue of care throughout pregnancy. Culturally competent care and the inclusion of cultural traditions within prenatal care, and a community-based approach that includes elder women, fathers, and other important individuals will not only increase utilization of care during pregnancy, but will empower these women during their pregnancy. Some examples of some interview questions that could be used when working with women would be, you know, how do you define health and wellness, and what do these terms mean to you? How do you view and define pregnancy or pregnant women in general? How do you define prenatal care? What does the term mean to you? Describe a typical interaction with a physician. What do you see as some of the benefits of prenatal health care? And what do you see as some of the drawbacks? More questions would be, what do you see as some of the drawbacks of prenatal health care? And what barriers to prenatal health care do you see for American Indian women? So, based on that, what are some of the solutions to these identified drawbacks and barriers? What are your opinions on current models of prenatal health care? And how would you define a traditional American Indian view of prenatal health care? So those 3 questions right there, I think, are very important questions for programs that are providing services to pregnant Native women. So that I've been in the process of rebranding this recovery program. So not only did we change the name, part of changing the name was to help reduce stigma and have these people feel more open to coming here. And not only are we just a substance abuse program, I'm working on opening it up to the community so that people don't just look at my program as we just do substance abuse treatment. I want to open up the cultural programming as part of prevention to this community, which will include bringing elders into the program as well. So some of these elders can share some of their cultural knowledge with the clients that seek services here. When I talk about wellness, I use the medicine wheel in all of my work as a mental health counselor, because we go through these different phases of life. And when I do wellness with my clients here, instead of a relapse prevention plan, I might call it their wellness plan. And it is in the form of the medicine wheel. So you see these colors here that represent, the 4 directions, the stages of life from being a baby, an adult, a youth, and an elder, and then also the mental, spiritual, physical, and emotional aspects of life. So when I have them do the medicine wheel, each area I have lines off in the corners there to where they can create this for themselves and put on there what they do to meet their emotional needs. What do they do for their mental needs? What do they do for their spiritual? And what are they doing for themselves physically? Which this can easily be applied to women that are pregnant and, even the father of the child, so that they can have their own wellness wheel, that they know that these are the things that they do for themselves to help themselves. Strategies for practice. 3-generation extended family is common. I just had one of my staff show me this awesome calendar. I wish I brought it in here. I didn't realize that was him on the cover, but it was a Crow Fair calendar. And it's a picture of these 4 men riding horses, and they're all in their traditional regalia. And the cultural counselor that I have here is the first one. Then there's his son, his son-in-law, and then a grandson. Very beautiful picture. So there are, a lot of Native families who are very close, and they have those generations in there. So when we look at the 3 generations, it's often, grandma seems to be the hub of the family, and then it goes on down from there. Discipline and education are frequently delegated to grandparents, aunts, and uncles, leaving economic matters to biological parents. So in my own family, I say I was raised by my grandparents, but it's because I chose to go there. My mom was always, busy working. And so I just wanted to be with my grandma all the time. So that's kind of how that happened. And of course, my mom didn't stop me from going there. And then we look at our aunts and uncles as other parents. So they are parent figures for us. It might be important to determine if she will be the primary caregiver of her baby. So like I said, there may be some women that are going to go to work. So who's going to be the person who watches the baby if mom has to go to work right away? And it's not unusual to have a home without a clock. I often use the story about my grandfather in a lot of my cultural presentations. I bought my grandfather a watch one time, and I noticed he wasn't wearing it. And I asked him why he wasn't wearing it. And he told me that it bothered him. And, it never dawned on me to think that this watch is not something for my grandfather as a traditional Arapaho man. And he said, it really bothered me. He said, how I tell my time is I get up in the morning when the sun comes up and I eat something. He said, when the sun is up, straight up, he said, I have lunch. He said that when the sun is going down, that's when I have my dinner. So that he didn't need a clock was basically what he was pointing out to me. And, it's not unusual. That's why we always say we're running on Indian time. And we may have to examine the client's time orientation. And here where we run groups, we often have clients running in late, I'll still allow them in, but, things happen. And when I do my sessions, I like to put time between them, knowing that, there's a good chance somebody's going to run late for some reason. Looking at the beliefs, values, and taboos, again, these vary from tribe to tribe and from individual to individual. Watching and listening are often the preferred modes of learning. We're different, in all learning settings, even in educational institutions, we learn differently from, the non-native people. And like I said, being an Arapaho in Crow country, I have to be mindful of that. I think this is a while back, not too long ago, somebody had pointed out that, wearing all black was not something that was looked fondly upon in this area where I'm at. And I explained to them where I come from as an Arapaho, black for us is a color of happiness and strength. Our tribal flag has black and red in it. So I said it, so it's not that I'm being offensive to you. This is just my culture is different from yours. So we have differences in our tribes. Some written agreements, we may frown on these because historically treaties have been misused or obtained under false pretenses, all lies, which also leads to distrust of such documents. So we need to allow the patient enough time to consult if they desire. So if, we have to be reassuring of their confidentiality here. Some strategies for education would be to begin with establishing rapport, communication that you care about the client always opens up communication. You'd want to use charts, clipboards. These other things could be barriers to establish rapport. So oftentimes I have my staff that have to do assessments here, as I'm sure they would be doing in a doctor's office. So sometimes they just feel like those could be barriers. Sitting face to face in an unhurried manner, being patient with these people, and get to know them before proceeding with care and teaching. Some cultural considerations is sharing stories as a way of education, keeping sessions informal in nature and conduct them in comfortable settings, as well as allowing for flexible start and end times. I learned from my personal experience that natives prefer to work without time pressures or constraints, if at all possible, Indian time. So, we're planning some family events and we want to be mindful of, not making everything, the approximate times of when we're going to do things. Learning styles, again, I mentioned watching and listening is a preferred way of learning. Asking questions to be, can be considered rude and insensitive. Do not look into the eyes or force eye contact. Some people seem to see that as disrespectful or take the soul away. And being in the mental health profession for all the years that I have, I do know that some, people can be listening to me but not looking at me, and that's just the way they feel comfortable. So asking questions is showy and brings attention to oneself. Patience and keen observation skills are virtues of educational environments. Educational programming, storytelling should be similar to Aesop's fables. And I haven't noticed at the clinic here when I go to the clinic here in Crow, but on the reservation where I come from, they always show these little video stories of Iktomi, and they're always related to healthcare. So I always thought those are kind of cute. Age is looked up to for wisdom and counsel. So, it's always good to consult elders. Materials used should be used with care and to be sensitive to tribal views. Talking circles work. Focus should always be possible, and it may be necessary to employ a Native American educator. So stories should teach a lesson. After an educational program is implemented, it must be evaluated for effectiveness and whether previously specified outcomes have been achieved. So whatever you plan to do, is it working? Indigenous helpers should develop culturally sensitive instruments, appreciate the importance of acculturated individuals in transmitting new ideas to more conservative members of the tribe, train respected natives as interviewers and lay caregivers, use Native American homes rather than clinics as primary sits for education and data collection, and use the clan should be tribal structure. I apologize for some typos here, but I'm going to go through and fix these before I send them to be sent out. For medical records and sampling procedures. So this is for future research for people, if you're going to go do research, that these are some good points to keep in mind as you do that. Research strategies would be, the current research strategies do not present a comprehensive view of Native American healthcare beliefs and practices. Many tribes have little or no research in rural or reservation settings. Native Americans are often not included in nationwide health surveys and do not include tribal affiliation. So if they do, we might be put in an other category. Generalizability may be limited, and specific tribe or tribes should be identified when the research is done, and approval from all tribes that do participate must be done. So each tribe, I believe, has their own protocols for doing research, and my preferred way is having it done by natives, for natives, to benefit the people and to share that knowledge with them as well. Vital statistics. There is a turbulent history of Native American and government relations characterized by periods of neglect. There's a profound mistrust of non-Indian curiosity and intervention. Data is virtually non-existent in textbooks and lay healthcare documents. When writing or reviewing for media, every effort should be made to include statistical information and to point out areas where more research is needed. We always need more research, but we also need natives out there doing it. Jacobson in 1994 shared this information of summarized recommendations and points to consider when planning or reviewing research of natives that should include the following: as possessing a comprehensive knowledge of the recipient culture, plan research that meets the felt needs of the recipient society, identify and avoid negatively charged words such as research and experiment, and use a Native American advisory committee, preferably compensated, to assess the effect of the research process and possible findings on the community. So like I said, I consider myself to be an Indigenous researcher. So I know I've been contacted by my tribe recently for a couple of projects that they're working on, and I'm always glad when they contact me and say, well, we thought of you, because of these things that you do. So I'm always honored when I'm asked to do that for my people and not somebody else doing it. And one of these things that I've been asked to work on is actually in a museum. It's talking about the Sand Creek Massacre of my tribe. I'm a descendant of the Sand Creek Massacre. But these people in Colorado went on ahead and did their own presentation in the museum or display of the Sand Creek Massacre. And I guess when our tribal people went to look at it, they were just offended by it. So we're actually being given the opportunity to redo that. And so I'm glad that I have that inside knowledge to, be able to take on that project to help the people. So it's good that, we need to support our people that are going to college and really encourage them to get into doing some research that'll benefit the people. Some future recommendations would be to remain realistic regarding study focus, goals, and short-term practical application of findings. Share your findings within the community in a style meaningful to them that will maximize relevance for program planning. Protect community confidentiality as well as subject confidentiality. Avoid press releases which create barriers. Go unbiased study completion and access to willing participants. To summarize all of this, we should have the awareness to traditional lifestyle and healthcare beliefs of Natives as the first step to culturally sensitive practice, education, and may be used as a resource for teaching. Spending time to build relationships and express sincerity and caring goes a long way in establishing the trust needed to provide comprehensive care, and teaching to a community has often been overlooked. A genuine desire to provide quality care will likely be perceived in a positive manner by Native people. So whatever research is done, whatever work is being done, it's really important to share it back with your community in a culturally respectful way. So it's not just to do it for the sake of doing it for one thing, but being able to share that, I think, increases knowledge of the entire community. And in conclusion, there is always a need for culturally competent care. Inclusion of cultural traditions within prenatal care is something I think healthcare providers should take into consideration when doing the prenatal care in the clinics. Considering a cultural broker case management program with American Indian women, a comprehensive cultural competence training for healthcare providers overall, and a community-based approach that includes elder women, get the fathers involved, and other important individuals can increase utilization of care during pregnancy and to empower those women throughout their own pregnancy. And that is it. I always say haho, thank you in Arapaho for taking time out of your busy schedules to attend the session today. There is my email included there if anybody has any personal questions or special requests. I'm always open to doing research on special topics that people out there in Indian country would like to learn more about. So feel free to shoot me an email if that's something you're interested in, or letting Megan know as well.
Yes, thank you, Avis. That was what I was going to just say is, we always like to focus our topics on the need. And so if anybody ever has an idea that they want us to present on, please let us know. Avis does a ton of research on any topic that comes up. And so we value, what people want, and this is for you guys. So it was good to talk to some of you behind the scenes through the chat. Obviously, this is a very important topic. And so we have set up another webinar for next month on March 9th at noon Central, and that'll be talking about the postpartum care and cultural considerations, and Avis will be doing that one too. So if you liked this, please join us again next month for that topic as well. And like I said, any questions can go through Avis or myself. We try and do our best to answer them. You guys will receive these slides, of course. Avis is going to update her PowerPoint where she saw some things she wanted to change. And so those will come out in the follow-up email. And I did put our post-survey link in the chat box here. But if you guys have any questions, we have a few minutes. If you don't mind, unmute yourself and feel free to address Avis and ask a few questions. I know people get shy, so, you know, nobody likes to talk all the time on webinars, trust me, but.
I'm going to jump out there. This is Alida Montiel. I'm a member of the Yaqui tribe here in Arizona. And I was fortunate that I was able to have my children at home with midwives.
Wow.
And of course, they're grown up now and have grandchildren. But I found that one of my daughters, when she had her birthing of my grandson, it's been 3 years now, at the Phoenix Indian Medical Center. At the time, labor and delivery was operational, and she had a great experience. She had the midwife, she had the suite, where there was, of course, the hospital bed for her, but then there was a bed in the same room. They had remodeled it. And so my son-in-law was able to stay there with her through the whole process. And it was very nice. Of course, it's an older facility, but it was where we were able to do our water ceremony, our water blessing. We're able to hang our feathers. We were able to get the placenta and so forth, the umbilical cord, you know, all these kinds of things that are really important. But I don't want to go into too much detail, but that was, you know, I am aware of the difficulties, you know, because I went to Indian Health Service for all my prenatal care with my children, but then I also had a midwife and had the children at home. So I'm aware of those barriers at some facilities, but I do want to say that that was greatly improved at the Phoenix Indian Medical Center. This was about 3 years ago. I know that they had to temporarily close L&D, and it's just something that we've been pushing very hard to get, you know, the L&D reopened, fully operational, get all their issues resolved. And so we just respected what they did and helped it meet our needs. And my family had a good experience. Thank you.
Thanks.
I think we have time for one more if anybody wants to chat.
I have a question.
Sure.
And this is about, you had said how you renamed the alcohol drug recovery program.
Yeah.
Did you present that to the group? Did you have to go to council, or how did you go about that in the best possible way?
Well, the tribal chairman is my supervisor.
Oh.
So I had shared with him, you know, just the name Recovery Center itself, I felt created, you know, more stigma to people wanting to come here for services. And the part of the rebranding was just completely restructuring the program and how it was running here. So I presented it to my staff, we presented it to the clients, and we all decided that we would do it like a contest to the community. So the name came from the community. We had several entries submitted to our program, and we just, as a group, sat down with all of the entries that were made, and just like you would vote anything, like how many for this one and how many for that one. And we finally narrowed it down to the Absalokai healing, and Absalokai is the Crow people. That is their name. That is their way they say it, and they don't say it, Crow. It's Absalokai. So I'm learning a lot as I'm here, and I feel it's just more meaningful for them to come from them. So it wasn't a name we just made up. We had like a contest in the community. We put it out on social media. Hey, we're going to rename our program, and we want to hear from the community. And so a lot of people got a chance to have input into the renaming of the program.
Plus, that seems like it's a good way to promote it for people to participate or get help from too.
Yeah, and surprisingly, since this is a perinatal care presentation, the person that like won our little contest, she was a pregnant lady. And so she came in from the community. She was really shy, but I was like, you're the one that's naming the program, so you get to say you named our program here. And we gave her like a gift basket with several different items in it. So there was a prize, and I think we gave them like a $50 gift certificate for a store here that's on the reservation that they could go and shop there. So she was
Very
happy to get that. And then we posted it up like, hey, this is the person that won. She's the one that renamed the program. And so she is a Crow tribal member.
Very nice. Thank you for explaining. I appreciate it very much.
You're welcome.
Thanks for asking her, Jean. So yeah, we're going to do, like I said, the postpartum session next time in March on the 9th at noon. And any questions for us in the meantime, please let us know via email. And we thank Avis, of course, for being here with us and sharing all of her knowledge, as always, with myself and all of you who have joined today. It's truly an honor to work with her. She is great, as most of you already recognize by your comments in the chat. So thank you, Avis, and we'll see you guys next month, perhaps. Thanks for taking the time out of your day, and everyone stay well. Okay, thank you. Bye-bye.